Thank you so much for that introduction, Nuratso. As Nuratso mentioned, I will be presenting findings from the Access study on behalf of my colleagues who are, some of which are sitting in the audience right now, which speaks to factors influencing initiation, continuation, and discontinuation of oral PrEP in South Africa. So just to highlight, there are no conflicts of interest. So the Access study. So in order to learn from programs, early programmatic learnings, the National Department of Health asked the USAID-funded Options Consortium, as well as the Bill and Melinda Gates-funded Prevention Market Manager, to conduct operations research on selected facilities which were rolling out PrEP, specifically to female sex workers and men who have sex with men. So just to give you a bit of a background on South Africa's rollout, South Africa started rolling out PrEP in June 2016 as part of a phased rollout starting with female sex workers. And the rollout was subsequently expanded to men who have sex with men in 2017, and then to adolescent girls and young women. So at the time in which the Access study was conducted, there were 16 facilities in which PrEP was being provided. So the phased rollout for rolling out oral PrEP is done so in order to create a rapid learn and adapt system. Key to that rapid learn and adapt system is operations research to give us rapid evidence to feed back into programs. So operations research is needed for program implementation. Out of the 16 facilities, we selected 9 facilities servicing female sex workers and men who have sex with men. And this selection was based on delivery mode and PrEP uptake. So with regards to the study methodology and objectives, the study employed a cross-sectional descriptive study design, and we had 3 main objectives. The first objective was looking at clients and examining what factors influence their decisions to initiate PrEP, to continue on PrEP, and to stop PrEP, and that is the focus of my presentation today. The remaining 2 objectives looked at providers and their knowledge, attitudes, and practice behaviors around providing PrEP. The last objective looked at examining oral PrEP communication and marketing mechanisms and to look at their effectiveness. So just to highlight how we selected our sample and to give you an idea of our sample sizes, at the 9 facilities, we recruited HIV-negative individuals who are 18 years and above, who are accessing services at any of these 9 sites, be it a fixed or mobile site. So the study began with a survey, and we enrolled 317 clients. After data cleaning, we had 299 clients. And this was a mix of female sex workers, MSM, and populations who did not identify as either a female sex worker or MSM. So our aim was to have an equal representation of clients who are currently using PrEP, who had stopped using PrEP, or who had never used PrEP. So we could get perspectives from all clients. We further went on to conduct in-depth interviews, and we enrolled 29 clients, primarily of which were current users. So in terms of participant demographics, if you turn your attention to female sex workers, the mean age of female sex workers within the sample was in their late 20s, and within MSM and other was in their early 30s. Our sample was primarily single, never married, as well as South African. In terms of age demographics, we found that our age demographics were in line to what was seen in the national rollout. So if you turn your attention to clients who had never used PrEP before, we found that over half of clients who had never used PrEP before had never been offered PrEP. So of that group that had never been offered PrEP, over half perceived themselves at risk, and 91% had also tested for HIV. So this is highlighting some missed opportunities in terms of offering PrEP to clients who believe that they are at risk. With regards to other reasons, such as decline of PrEP, we found that for female sex workers, side effects seem to be a prominent reason why they opted not to use PrEP. So if you draw your attention to those who had been offered PrEP and initiated, we asked them a single response question as to why they decided to initiate on PrEP. And primarily, they had believed that they were at risk due to their sexual activity. With regards to clients who had opted to continue on PrEP, we asked them a multiple response question as to why they opted to continue on PrEP, and we found that this was similar to their reasons for initiation. They perceived risk associated with their sexual activity. If you look at the dark blue bars representing female sex workers seem to weigh equally on sexual activity, feeling at risk of HIV, and having multiple sex partners as drivers to continue on PrEP. Second to that, they believed that some of their clients could be HIV positive, and this was an additional driver to continuing on PrEP. So we also looked at clients who had stopped using PrEP, and we asked them a multiple response question as to why they decided to stop using PrEP. And we found that over 70% of clients, irrespective of key population status, identified that side effects was the reason why they decided to discontinue on PrEP. When we looked further at what side effects they were experiencing, it was the known gastrointestinal side effects, so your nausea, vomiting, dizziness, and headaches. When we looked at the time period in which they were on PrEP before they dropped off, we found that the past users who had discontinued PrEP as a result of side effects did so within the first 3 months of use. So we went further on to look at the experiences of side effects in those who were currently using PrEP versus those who had stopped using PrEP. And we found that current users had reported experiencing lesser degrees of side effects as opposed to past users. And in general, current users did not feel that side effects were intolerable and did not seem to feel that side effects affected daily life. Conversely, those who had stopped using PrEP found side effects to be intolerable and affecting their daily life. So when we asked current users in in-depth interviews about their experiences with side effects, they mentioned that even though they experienced side effects, they were determined to use PrEP, and they employed certain strategies like going to the clinic and speaking to a healthcare provider or adjusting the timing in which they took their pill in order to mitigate some of those side effects. So if we move our attention over to the counseling sessions that we have when providing PrEP, we ask clients to recall the topics that were covered in the counseling sessions. And we found that under 50% of clients remember being counseled on managing side effects. So if you draw your attention to the side effects column, you will see that quite a number of clients recall being told about side effects, whereas a much lesser number have been told about how to manage their side effects. So trying to just sum up all that I've just presented and reflecting on these findings, we highlight that there are some missed opportunities to offer PrEP within the facilities. However, from this survey, we really do not know what these reasons are. We are hoping that the in-depth interviews that we've conducted and are still analyzing will shed more light on this, so this definitely warrants more investigation. In terms of what drives clients to use PrEP and to continue on PrEP, we found that knowing your risk was a big driver to initiate and continue on PrEP. And knowing what drives clients to initiate and continue on PrEP helps us to tailor our demand creation. With regards to clients who had discontinued on PrEP, we found that side effects seems to be quite a prominent reason. And coupled with side effects, the counseling messaging on how to manage side effects seems to not be as well covered. So where to from here? The operations research is meant to feedback rapidly to programs in order to improve programs. So from these findings that I've presented, there has been some actions as well as proposed actions on how to move this forward. So with regards to offering PrEP to those who are at risk, the clinical and counseling training has been revised in order to enable providers to provide client-centered counseling. Coupled to this, the counseling training has also emphasized how to counsel on managing side effects and to set expectations on what you can experience with side effects and what to do to manage these side effects in a client-centered approach. Also, with regards to our providers are the gatekeepers of any new technology that comes into the market. So it's very important that we understand what their perspectives are in terms of providing PrEP. So we have a batch of in-depth interviews that we are currently analyzing to determine what these perceptions are. We do plan to convene a workshop with the providers in order to determine what their perceptions are around providing PrEP to key populations. So I'd just like to take this opportunity to acknowledge the National Department of Health for their support throughout conducting the study. I'd like to acknowledge the implementing partners who provided us with access to their sites, as well as the providers and clients who participated in this study. Without them, we would not have these perspectives. I'd like to acknowledge the data collectors who collected our data, as well as the Access Study team, which comprises of VITS RHI, the Prevention Market Manager, and FHI 360. Lastly, I'd like to thank the USAID, as well as our Options Consortium partners for all their assistance. Thank you.
Thank you very much. Thank you very much, Diantha. We've got a couple of minutes for a couple of questions. Anyone with a question, please come up to the mic, introduce yourself, and phrase your question succinctly. And yes, thank you. Mic number 5.
Thank you. My name is Neluka. I'm from LGBTQ+ Youth Network in Asia and Pacific. We did a survey in 4 cities in our region about adolescents' preparedness to use PrEP as an additional prevention method. Most of them were referring to how PrEP would empower them to take control of their sexual health. So I wanted to ask you, in your research, have you been able to talk to the PrEP users about how being on PrEP contributed to feel more confident about their sexual lives, about sexual pleasure? Have they spoken about any of that?
So thank you so much for your question. We did not specifically ask them with regards to their sexual lives and pleasure, but we did have IDI in-depth interview questions with regards to empowerment in our survey and in our in-depth interviews. So those results are still pending and will come out shortly.
Thank you. Mic number 1.
Hi, Ace Robinson, Los Angeles. Great talk. Thank you so much. Quick question related to, specific to the South African community. When you're looking at language, mother tongue language, and the language that was used to give education and also engage the clients in care, was there any difference in the utilization of PrEP and adherence to PrEP, part number 1. And then part 2, related to sexual initiation and voluntary versus involuntary sexual experiences, whether there was any difference in a desire or our ability to control one's sexual health and adherence.
So with regards to the mother tongue utilization, we did not find within the sample that there were any differences. So there were a wide range of ethnicities that participated in the study, and there was no specific difference that we saw within that. So with regards to voluntary versus involuntary sexual encounters. I hope I'm getting your question right.
Yeah, we often see that condom utilization for individuals who their sexual initiation was involuntary. Condom utilization and other sexual safer practices are decreased or diminished versus individuals who sexual initiation was a voluntary activity. I don't know if you had any characteristics.
So our survey did not look at voluntary versus involuntary sexual initiation, and our sample was largely of female sex workers and MSM, so we did not capture the voluntary versus involuntary experience.
Thank you very much. Thank you very much, Diantha. Our next presenter is Dr. John Kinutia, who is an obstetrician and gynecologist and head of research and programs at Kenyatta National Hospital. In addition, he's an honorary lecturer at the University of Nairobi, Institute of Tropical and Infectious Diseases, and the Department of Obs and Gynae. He will be talking to us about PrEP uptake among pregnant and postpartum women, results from a large implementation program within routine maternal child health clinics in Kenya.
Yeah, thank you. On behalf of my co-authors, some of who are in this room, I want to thank the conference organizers for inviting us to give this talk on PrEP uptake among pregnant and postpartum women. High incidence of HIV has been reported among pregnant and postpartum women in sub-Saharan Africa. The incidence, in a recent meta-analysis by Alison Drake and colleagues, found an incidence of 3.8%. Now, this incidence is similar to what is seen in groups which have been traditionally regarded as high risk, such as female sex workers and HIV serodiscordant couples. The increase in risk of HIV transmission during pregnancy is due to hormonal and physiological changes that occur during pregnancy. It could also be due to the sexual behavior of their male partners. Within PMTCT, low male partner engagement means that quite often women who test HIV negative and are in serodiscordant relationship do not know that they are that their partner is HIV infected and therefore do not take precautions to protect themselves from infection. Thompson and colleagues have looked at HIV risk per unprotected coital act, and what they have found is that during pregnancy and in postpartum, the risk is actually much higher. It's estimated that approximately 40% of infant infections are due to acute maternal infection. Women with acute HIV are more likely to transmit the virus to their infants because of the higher viral load and also because of absence of HIV immune responses. In addition, acute HIV infection is often undiagnosed, which means that the women do not receive either maternal or infant antiretrovirus. So, as the PMTCT programs expand and come up with more effective ways to identify and promptly initiate on treatment women with chronic infection, what we are going to see is that the relative contribution of chronic HIV to MTCT will diminish, but at the same time, the contribution of acute infection is likely to be moving up, which means that initiatives which are promoting primary HIV prevention, including use of PrEP, are actually critical, not only to protect the women and ensure that they remain HIV uninfected, but also in supporting efforts towards EMTCT. WHO and the Kenya ART guidelines support use of PrEP during pregnancy and in postpartum period for women who are at substantial risk of HIV. The Kenya Ministry of Health has developed a risk assessment tool to assist health workers be able to identify women who are at risk of HIV and who would benefit from PrEP. But even as we think about PrEP implementation in pregnancy and postpartum, there are a number of unanswered questions. One, will pregnant and breastfeeding women recognize risk for HIV? Which pregnant women should be offered or receive PrEP? Will women accept PrEP? Will women adhere? Because effectiveness of PrEP is dependent on adherence. Now, the PREA program, PREA stands for PrEP Implementation in Young Women and Adolescents. And this program is delivering PrEP within MCH and FP clinics in Western Kenya. It's part of the Dreams Innovation Challenge, funded by PEPFAR, managed by JSI, and implemented by University of Washington. The PREA sites are within Kisumu County in Western Kenya, and the program was implemented in 16 of these facilities. For this evaluation, we are looking at PrEP acceptance and cofactors of uptake. Women who are who are seeking antenatal care or postnatal care, HIV uninfected, are screened for HIV risk factors by a PREA program nurse and also assessed for willingness to use PrEP. We have employed two methods of PrEP delivery. In the first model, the PREA program nurse provides MCH service, thereafter assesses the women for HIV risk and offers them PrEP. In the second model, the facility nurse offers MCH services and the PREA program nurse provides risk assessment and PrEP offer. PrEP is dispensed at the same visit and within MCH clinic. We've used logistic regression to determine cofactors of uptake, and we have assessed data that is covering period between November 2017 and May 2018. Over this period, within the 16 PREA sites, 9,171 women have been assessed for HIV risk factors and willingness to consider PrEP. Of these, 52% were pregnant, 48% were postpartum. 78% of the women did not initiate PrEP. 1,993, which is 22% of women assessed, were initiated on PrEP. 45% of these were pregnant and 55% were postpartum. The median age of women who were offered PrEP was 24 years, 46% were less than 24 years, 84% of the women were married, 34% did not know the HIV status of their partner. Among pregnant women, the median gestation age was 26 weeks, and 45% of the women were making their first antenatal care visit. Frequency of PrEP initiation differed by partner HIV status, being 79% among those who reported a HIV-positive partner, 37% among those with a partner of unknown status, 12% among those with a HIV-negative partner. PrEP initiation was more frequent in the postpartum period among younger women and among women who were unmarried. PrEP initiation was associated with reporting transactional sex, being diagnosed with an STI, reporting to have been forced to have sex, and experience of intimate partner violence within the last 6 months. Also, the women who reported having a partner of unknown HIV status, those who are younger and in the postpartum period. Among women who had risk factors for HIV but did not initiate PrEP, the most frequently cited reason for not initiating PrEP was the need to consult partner, cited by 38% of women. Low perceived risk of HIV was cited by 35% of women. Pill burden, 13%. Fear of intimate partner violence was reported by 4% of women. And fear of effects of PrEP on the unborn baby was reported by 2% of women, those who are pregnant. So in conclusion, from our program, we can see that 1 in 5 pregnant and postpartum women who had risk factors for HIV accepted PrEP. PrEP initiators were more likely to have risk factors for HIV, intimate partner violence, and fear of effects of PrEP on unborn baby were frequently reported as barriers to PrEP uptake. And 1/3 of women reported that their partner, they did not know the HIV status of their partner. From our study, we can see that routine MCH clinics can be an important platform to identify women at risk for HIV and also to offer them intervention, including PrEP, which can prevent HIV acquisition. In view of the large number of women who did not know the HIV status of their partner, innovations are needed to come up with better strategies to increase knowledge of male partner HIV status. We are looking at our data to look at adherence and also to look at rates and reasons for discontinuation with PrEP. We really are very grateful to all our PREA program participants from whom we have learned so much, to the PREA program staff, the Kenya Ministry of Health, who have been at the forefront in supporting PrEP within the country, the Kisumu County government. PREA is funded by the United States Department of State as part of DREAMS Innovation Challenge managed by JSI. Thank you very much.
Thank you very much, Dr. Kinutia. We'll take a couple of questions. Okay, while people are coming up to the mic, I think what is resonating from the first two presenters is that we see perceived risk as a major driver of PrEP uptake as well as maintenance of PrEP. All right, mic number 2.
Okay, good afternoon. My name is Dr. Johnson Okolie. I'm a Nigerian. I work for Management Sciences for Health at INGO. So my question is, in your conclusion, you mentioned that some of the people who initiated PrEP, some of the pregnant women who initiated PrEP, had their partners who had a HIV or non-HIV status. So my question is, do you think that it is maybe the usefulness of the PrEP here is not well defined? For example, I know that population may be small, but if we have if a large number of women whose partners have a non-HIV status initiate on PrEP, will it not be difficult for you to define if PrEP actually, went away or kind of went ahead to prevent HIV in this population? The other question is, okay, thank you.
Yeah, thank you for the question. If I'm to understand you correctly, you're asking whether it is reasonable to initiate a woman whose risk is that her partner is of unknown status. I think you'll agree with me that having unprotected sex with somebody of unknown status is a risk factor. And that is the context in which we are looking at. There are a number of studies which have looked at the risk of transmission. And during pregnancy, since as I mentioned, the male partner knowledge of male partners is quite low, quite a number of those women are in HIV discordant relationship. The man may either be a known positive or a known positive, but either way, the risk for transmission in that context is high. And in fact, it is better if the man is known to be positive, because then they are already in treatment, they are on ART, and they are likely to be suppressed, which would mean that the risk of transmission is lower. So it is a risk factor. Even our guidelines identify having sex with somebody of unknown status as a risk factor for HIV, and that is somebody who can benefit from PrEP. But we go a step forward. We are also promoting self-testing. So the women with a partner of unknown status are also offered the self-test so that they can go home, and if that relationship allows that, the male partner can know their status. If the partner is negative, then they are not at risk. On the other hand, if the partner is positive, then it's an opportunity for the partner to get into care, and in that period, for the woman to be using PrEP to protect herself.
I'm afraid we've run out of time, so our two speakers at mic number 4, please catch up with Dr. Kinutia at the end of the session. My apologies. Thank you. Our next speaker is Jordan Kiyongo, he holds a master's degree in molecular biology. He's also an MPH, he also holds an MPH and is a PhD candidate. He's a member of the Kenya National PrEP Technical Working Group and the Kenya AIDS Research Coordinating Mechanism. He will talk to us, his presentation is entitled, How Long Will They Take PrEP? Oral Pre-Exposure Prophylaxis Retention for Female Sex Workers, MSM, and Young Women in a Demonstration Project in Kenya. Jordan.
Thank you. So thank you very much for this chance to present our data, again, on behalf of many people, and also to you all for taking time to come and listen to the different presentations that are being done today. So I'll very briefly take you through the background of the talk I'm about to give you, and also then give you the procedures that we did as part of the demonstration project, give you the retention results, and then explain a few reasons why some people stayed and some people left the project, and then we can have a very quick reflection on what this means for real-life implementation. So in 2013 in Kenya, and the context of this is PrEP was not yet rolled out. There were no guidelines. The guidelines that Dr. Kinuthia has just shared, they were not yet there. We did a feasibility study among female sex workers, men who have sex with men, and young women. And among the many questions that we asked, one was, would you be willing to take PrEP? So remember, this is a theoretical setting, so there's no PrEP, there's no guidelines. And an overwhelming majority of them said yes. So for all the three populations, over 80%, most of them say they will be willing. Keep your eye on the young women percentage at the very end, because that's relevant later on. So we then went ahead in 2015 to do a demonstration project. And in this project, we were providing PrEP in private and government facilities, looking at if it is feasible to deliver PrEP in real-world settings, looking at different populations, so the same three populations. And we were able to screen and find a total of 2,100 plus individuals who are eligible for PrEP. That was our target population. That was our target for this project in 3 different counties in Kenya. So what did we see in terms of retention? And this is where it gets juicy and maybe in not too nice a way. But before we get there, one of the things that was supposed to happen then is once you get screened and you're found to be eligible, and that was during that first visit, then we would give you 2 weeks, at which point you would have time to think about whether you really want to take PrEP, but you would also have time to do the blood test. So look at creatinine testing clearance, looking at hepatitis B and C, whether you're infected before we initiate you on PrEP. And then after that, you come back after 2 weeks, and then you'll be initiated onto PrEP. And then you do follow-up visits every month up to the 4th month, where if you are a good adherer, you'll be given the option of taking PrEP for 3 months, or still come back after 1 month if your adherence was not very good. So that was the structure of the program. And you were supposed to be followed up over a period of 1 year, and then exit the study at the end of 12 months. So to the results. So if you focus on the first set of results, either the female sex workers, and if you focus on the first one. So the first bar is the total number of people who were eligible for PrEP. They were screened. And then the next bar refers to those who were initiated. So you can already see after the screening, 2 weeks later, we already lost a number of people who did not come to initiate PrEP. And then if you take this as the total number of people who initiated PrEP, by month 1, you only had 40% of them still taking PrEP who came back for the next dose. And that number continuously decreases up to, this is data until 6 months later. And the trend is the same for all populations. But the reason why I told you to keep an eye on the 85% is because you can see out of the ones who are eligible for the young women, the same percentage, slightly higher, came back for PrEP. So young women are willing to take PrEP. When they say they want to take PrEP, they actually are willing. This was in 2 different time points. But the interesting thing is that immediately you see a huge drop for the young women. So they are very willing, they start, and 1 month later they're out. So what is it that is causing them to drop out that fast? And the reasons are some of this. So I'm so glad that I came after the 2 presenters who came, because a lot of these things are shared across different projects. And side effects were big, and one of the reasons they said is, as you see there, is they say they had nausea, headaches, dizziness, running stomach, darkening of the skin, weight gain, loss of appetite, and they report this over a period of 1 day up to 1 month. Then if someone had a reduced perception of risk, then they dropped out of the project. And if they had a bad encounter at the facility with healthcare workers, they also dropped out of the project. And then there were a lot of myths and misconceptions. So remember, this is between 2015 up to 2017 when PrEP was rolled out in the country. And some of the misconceptions were around the fact that PrEP would make you impotent. It was a way of eliminating Kenyans. It was being used as a way of family planning or birth control, and that it even reduces your sexual urge. So you do get a lot of misconceptions about PrEP. Population-specific reasons for dropping out for female sex workers and MSM, so we group them here as key populations, was one around the packaging. And the concern is because it is an ARV, so people fear that if I'm seen with it, I'll be thought to be HIV positive. The pill color, we were using Truvada for the study, and in Kenya, there's a date rape drug that is blue in color. So the female sex workers will be afraid, and they would think that if I'm seen with this pill, then it will be feared that my intention is to actually drug someone or my clients. So because of this, they were afraid of taking PrEP and staying with PrEP. And then some say the pill was too large. Some people had challenges accessing the sites as well, and these were 2 different reasons. So for example, it could be that because the KP were very mobile, it's a mobile population, so, and at this point, PrEP was not available everywhere, but also issues to do with transport. So like this quote from this MSM who says, sometimes I'm going for a job far and I do not have transport that will bring me. I'm supposed to come, and so the transport that will take me back to the job and getting it is hard. So there were issues because we were not giving any reimbursement for these populations who were accessing here. But also during the first visit, the procedures were very tedious. We were doing a lot. It was taking a lot at the facility, so people were dropping out because of that. For the young women, there was the risk of social harm, but not just risk. There was also actual social harm. You see this young woman who says, when I informed my husband, he refused and told me that he should not find me using it. So I started taking the drug in secrecy. When he came to know about it, when he saw that bottle, he beat me to the extent of destroying my nose. So PrEP actually results in violence sometimes for the users. But apart from violence, there's also the risk of stigma for these young women. So these are some of the reasons why you saw that initial drop that you saw. And there's also lack of support from their partners, so their sexual partners, from their peers, but also from their guardians and parents. So the example of this young woman who stays with her aunt says, that was hard. I thought to myself, what will I do now? I was even afraid to tell my aunt because I did not know how she will take it. So I just declined. I had no otherwise. That's a very Kenyan saying. They say, I had no otherwise. For the few that stayed, why did they stay? The reason why they stayed was the opposite of why some of them dropped. So because when they had support from either their peers, their guardians, or their partners, then they stayed. So remember, we've talked about a case about someone who dropped because their partner was against them using PrEP. And this other one is they say, I took the drugs, I had to explain to my husband, if you find this bottle, it's not for the drugs you think that is for the virus. It is just for taking it. That way, the way I can just be taking Panadol as a painkiller, now he has understood when it comes to that time and he sees me taking a tablet after opening it, he doesn't care. So there is a place for explaining, and after understanding, then you get a supportive environment for the person to continue taking PrEP. Then also people who came to the facility to get other services other than PrEP, that was a motivator for them to stay. And then lastly, people who had social responsibility. So they were either taking care of their siblings or their children. They were willing to take PrEP because of their responsibility in the society. And then for all populations, if they had a positive encounter with the facility, with the healthcare workers, then they stayed. But also those who knew their risk. So similar to what Dr. Kinuthi just mentioned, they were willing to stay. As a quote from this female sex worker said that because of having multiple partners, having unprotected sex, you do not know their status. Like even those 4, I only knew the status of one person, and they do not want to come to the clinic to test. So the person decided to stay and take PrEP. So finally, what does this mean for real life? At an individual level, and these are just thoughts and reflections based on our work, PrEP is a choice. So we give people PrEP, but we also give them many prevention options. And people can decide to take PrEP, they can decide to use condoms, they can decide to use any other options they need for prevention. So we need to keep that in mind. I had a chat with Manju on Saturday, and one of the things she said, and this is not a verbatim quote, but it was something in this line, that the end game is HIV prevention and not PrEP use. So keep that in mind. Someone may refuse to take PrEP, but they may take condoms, and that's okay. They don't necessarily have to take PrEP. But the other thing is that my director always asks us, if you keep someone in a prevention program for 2 years on PrEP, would you consider that success? Would it have been better that your prevention program reduces their risk so that they can actually get off PrEP because their risk has actually gone down low? So one of the things that we need to be tracking as we provide PrEP is risk. And risk both objectively but also subjectively. Do the people feel that they're at risk? And are the metrics that you're collecting showing that they're at risk or not at risk? So the other thing that we obviously need to do is just provide information to address the myths and misconceptions, but also the side effects that they face that are real. Then at the health system level, we need to continuously train our healthcare workers. And this is important because there's a lot of information that comes out, but also important this second part that talks about values clarification. We are doing a study as part of the Options Consortium. I have to give a shout out to my people. That where you see, even though people have knowledge about PrEP, they may have attitudes that are negative towards providing PrEP to specific populations. So it's important that we train our healthcare workers not just to give them knowledge, but they have the right attitudes in terms of providing PrEP to all populations that need them. And then secondly, and this is important, that we need to think about providing PrEP in a differentiated kind of manner. We are used to providing it at facilities, but we need to think beyond the facility and think about, should we be following people where they are, taking it to the community, taking it to the hotspots, and being very flexible about the times that we provide. So for example, for us, the key populations would rather come in the morning or in the evening. The young women prefer to come during the day. So be very flexible about how you provide it. And then finally, and this to me is one of the most important things that we forget, is that we provide PrEP to an individual in a facility. Then this young woman, this female sex worker, this MSM, goes to a context that is different from the facility. So you give it to a young girl and they go home and they'll be having to take it where there is a partner, where they have their peers, where they have their guardians, in a context of a school setting. And if the information there is wrong, then these people will not be able to take PrEP. So the thing that I think, and I'm trying to push for, is that we need to provide interventions at community level so that people have the correct context within which they can be able to take PrEP and take it well when they need to take PrEP. That's important. And then the last point in this slide is that there is need for increased community education and engagement. As Mary Aikenhead from the Gates Foundation once said, let's make PrEP famous and make it easy for people to take. So as part of the Kenyan team, there's a lot of work that we're doing that speak to this. So if you have some time, visit the sessions that are highlighted here, including the posters and the talk on Friday that will focus on PrEP provision for young people as part of Team Kenya. And then this work is, as I said at the beginning, done by many partners, and it has been funded by the Gates Foundation. We worked very closely with the community organizations that are listed here in terms of providing them together with SWAP and other providers. Thank you very much.
Thank you very much. We have time for just one question. Mic number 5.
Hi, thank you. I have a question. Do you know how many people got infected with HIV among the people you work with? Because you said PrEP is just one strategy among others, but are these people using the other options of prevention? Thank you.
Yes, so we have some data about condom use and other prevention options. So we do have some strategies. We had a total of, out of the number that were recruited, a total of 4 people who were infected with HIV, but we also know that they were not taking PrEP because they did not come back. They came back to our facilities for services, but this was after missing out for 3 months or much longer. So no one who was on PrEP got infected. Yes.
And number 2, please make it quick.
Hi, hello. I'm Olga Denisuk from Alliance for Public Health Ukraine. So for the retention slide that you showed, did you calculate participants who didn't report having a risky behavior period for the follow-up visits, so they stopped using PrEP because of that?
Yeah, so we have data on risk. So we're collecting at every visit, we're collecting risk. But the slide there was just showing for all participants. And it is drop off from PrEP. If we know we gave you PrEP for a month, if you do not come back, then for this purpose of this analysis, we considered you to have dropped off. But we do have data on risk. And you actually do see for some populations that the ones who stay, their risk actually reduces over time. And then you also have better adherence over time. So there's a lot more analysis that I didn't show in this presentation. Yeah.
Thank you. Thank you very much. Thank you. Okay, from Eastern Africa, we move to Southern Africa. Our next presenter is Aspindile Magwaza, who joined the Maternal, Adolescent and Child Health Systems in Durban, South Africa, as a senior technical advisor to support a South-to-South technical assistance partnership program, which aims to scale up test and treat in 18 countries, and they are supported by PEPFAR. She will be talking to us about the cost and impact of PrEP implementation in Haiti.
Thank you very much, and thank you very much for attending this session, and we feel very honored to the organizers for considering our abstract. My presentation this afternoon will cover a little bit about EQUIP and EQUIP activities in Haiti, the rationale for PrEP implementation in Haiti, as well as describing the type of model and costing parameters that were used, and also summarizing the PrEP model scenarios and assumptions that were made. And I will also conclude by then presenting the results, the limitations, and whereabout PrEP implementation is in Haiti. So EQUIP is a project funded by USAID. It's over 5 years, and it supports the test and treat policy rollout in 18 countries. And in Haiti, that's what we support as listed, among which is PrEP, a demonstration project that will be starting soon. And most of our work has been on cost analysis, and this PrEP results that I'm sharing with you today is part of a bigger package where we're just supporting the ministry regarding their test and treat rollout policy, as well as their prevention goals. And we work with 3 implementation partners in Haiti that are supporting about 70 health facilities. And we are hoping that we'll have a stronger consortium with the ministry leading the PrEP demonstration project. So why considering this decision for Haiti? Just looking at this slide, I just want to highlight 3 points. The first one being the HIV prevalence at 2.1 based on the Global AIDS Monitoring report in 2017. But when you look at the general population HIV prevalence, and then you look at the IBBS, which is the Integrated Biological Behavioral Survey that was conducted in 2014 among key population, you find that the prevalence is much higher. But now you look at the UNAIDS 2016 report on the progress of 1990, and you see that at least about 55% of clients of ART coverage in Haiti by end of 2016, with 38 that are virally suppressed. And key population constitute about 1.2% of those on ART. So it was quite important that the ministry considers PrEP implementation for key population. So, as many of you may know, we use the UNAIDS Spectrum, which is an analytic tool used to support policy decisions for public health. And within the Spectrum, there is what we call goals module that is used to estimate effects of intervention and resource allocation on HIV infection and death. But it also brings coverage, and it looks at effectiveness as well as the distribution of PrEP users. The key parameters are as highlighted on this slide. Mainly the data we drew from the primary and secondary data from Haiti, where there was no country-specific information. We then use goals default data, and sometimes we also calculated some estimates, for example, the estimation for key population by key population type. So the assumptions and methods, this slide, I just want to highlight that with using goals, it assumes the effectiveness of each intervention and its synergic effect, predicting the number of new infections per year and related costs for each scenario, and also specifics about population risk groups. And then why we consider it, because it models directly PrEP, but then it also has a fixed unit cost over set analysis periods, so it doesn't allow, once a person has been initiated, the ongoing costs are not considered, so it considers fixed cost. And in Haiti, because there's just, at the moment, the key population have access to other prevention services, so we saw PrEP as an add-on service to other prevention services. So the steps that were taken in terms of the method that we used, firstly, we used an ingredient-based approach where we looked at different clinical services that constitute that are needed for a person to be initiated on PrEP, and then we added those unit costs to get the annual PrEP unit cost. And then we also looked at variation in coverage and adherence rate to generate the uncertainty limit with plus minus 10% variation in adherence. And lastly, we included the condom as one of the prevention tools, but used a separate analysis for that with general population at varied coverage levels as well. So in summary, these are our scenarios as presented. The first three are PrEP scenarios with varied adherence and coverage over the 7 years. And we aligned the 7 years because of the HIV strategy in Haiti is over a period of 7 years. And adherence, the assumption was that where there is less adherence, then there will be more coverage. Where there is more adherence, like 80%, there is much smaller coverage. We are able, people have self-efficacy and at higher beta. So as mentioned, the first step is the ingredient-based costing of PrEP. We considered all these components to come up with a unit cost in the first year, which ended up being 228. And then subsequently after that, it's reached to 173.85. And that 55 reduction really is, we assume that other services their sessions will be reduced in subsequent years as they go, as more and, clients are being familiar with the clinical consultation. For example, the adherence counseling session will be reduced from about 5 to about 4 sessions in a year. And also we noted that with the drugs, the commodities and drug costs may also be reduced over a period. So results, the first slide, I just want to highlight the total estimated intervention cost for the 4 prevention scenarios by year. So what you see here in 2017, you see that in all scenarios, there is quite a low total estimated intervention, but then there is a drastic increase, in particularly for the scenario 1. By 2023, you see that the annual estimated intervention cost is about 9.2 million, but also others, they also increase, but not as much as in scenario 1. And we note the red bar is the condom intervention at various coverage, as mentioned, and there is a modest increase only by 2023. The next one highlights the estimated cumulative infections are vetted and people on PrEP for the 4 prevention scenarios from 2017 to 2023. So what you see here on your left is cumulative infections are vetted, the number, and then on your right is the people on PrEP. And then the lines represent the 4 different scenarios. So the top line is the first scenario where you increase up to 30% coverage. So what you see here, you enroll people, about 48,000 people on PrEP, and the estimated cumulative infections are vetted will be about 4,492. And then if you enroll about 16,263, the estimated cumulative infection vetted would be 2,528. And so as 3,784, and then the estimation will be 1,165. So this slide, I just want to highlight that the cost per infection vetted. So firstly, in the first year, you see there's higher cost regardless of the scenarios. So with scenario 1 being the highest cost per infection vetted. But gradually, as you move through the 7 years, you see that the cost decreases immensely across all the scenarios. Most importantly, the scenario 2 and 3 remain relatively the same, and then the condom being the very low cost. In summary of the results, here we present the summaries of different interventions that I've highlighted, the total cost over the 7 years, and then the total infections vetted. What I just want to highlight here is that the scenario 1 similarly is very costly, but also it has a lot of number of infections that are vetted as compared to other scenarios. We also note that it's still, when you look at the average cost-effectiveness ratio, also is still high, and condoms remain the lowest. However, for the third scenarios, what we find that it was even higher, the incremental cost-effectiveness ratio, and more than the next most effective program. So the ministry really had to consider all this, and at the request of USAID, EQUIP was then tasked to rather focus on the demonstration project, while the ministry needs to consider these results because of the limitations as highlighted. Most importantly was that our analysis was aligned to a 7-year period, and that really underestimates the benefit of vetting for a whole lifetime on art, and overestimate the cost per HIV infection vetted. So where are we now? We have assisted the ministry to revise the HIV clinical guidelines, including PrEP provision, and they have endorsed the cost analysis report in considering where and how to implement PrEP in Haiti. They've established the TWG. And in the meantime, what is in process is that they're finalizing regulatory requirements and supply chain, as well as they are meeting with various donors to discuss about drug availability, and we are assisting with developing of tools as maybe 1 or 2 sites be selected, and then we finalize the community consultations, and we assist the ministry with the training for PrEP implementation, and then we finalize evaluation protocol that will help the ministry to really then make informative decisions regarding PrEP rollout in Haiti. I would like to acknowledge the innovation team as represented by these co-investigators and their respective organization. Also acknowledging USAID and the Ministry of Health in Haiti. Thank you.
Thank you very much. Question from mic number 5.
Hi, Judy Wasserheit, University of Washington. Thank you for these great presentations, both in terms of the last presentation with relationship to cost and with respect to some of the earlier presentations in terms of risks. One of the things that we need to be thinking about is the impact on other sexually transmitted infections. Part of what we're seeing in the United States and other high-income countries is historic increases in other sexually transmitted infections. And there's a growing body of evidence to suggest that at least some of that is related to changes in practices related to scale-up of this really important intervention that we have, this wonderful intervention, PrEP. So my question is, in the studies that have been presented and perhaps the others, what are you looking at other sexually transmitted infections? What are you seeing? How does that factor into your thinking about both risk reduction and cost, particularly with respect to the health of women and children?
So I'll let others respond to a more implementation side, but in terms of costing, the STI was included as well as Hep B vaccine as well as the screening. So we are considering other infections.
Are you factoring in projected increases or decreases that you might be seeing, or is this just, how are you thinking about that over time?
Well, regarding, this work was done early last year and with this country-specific data that we had, and our data was the annual data of 2016, so we had considered that. But then in terms of over the period, we'll be monitoring, because the ministry may consider to actually do another round of cost analysis, including a PrEP as a part of the combination prevention rather than an add-on service, where then we'll be considering others and how other sexually transmitted infections also impact.
Thank you very much. Some of these questions might be answered by our next 2 presenters, so we'll move on to our next presenter. Thank you very much. Our next presenter is Matthew Quaife, who is an assistant professor in health economics at the London School of Hygiene and Tropical Medicine. He's going to be talking to us about the cost effectiveness of MPTs in South Africa. Thank you.
Thank you. Good afternoon. Good afternoon.
Good afternoon.
Hey, excellent. Thank you for joining us for the second health economics presentation in this session. Thanks to the organisers for having us. I'm presenting some work we've done based at the London School in collaboration with partners at WITS, RHI and PATH about the cost effectiveness of potential multi-purpose HIV and pregnancy prevention technologies in South Africa. I've got no conflict of interest to declare, but I am presenting work that's been published in between submitting the abstract and presenting it here. So if you can't stand the suspense, then this is available in JIAS, but otherwise stay with me. I'm sure I don't need to say this. The context for this study is urban South Africa. South Africa is one of the largest and high-profile epidemics in the world, and it's a predominantly heterosexual epidemic with some nuances around women being at more high risk than men, adolescent girls being more high risk than boys of the same age. By high risk, I mean having a higher prevalence. And of course, sex workers face a high disease burden, as in lots of populations. In this talk, I'm going to be talking about MPTs, multi-purpose prevention technologies, and I'll credit the IMPT organization for these slides. An MPT is a technology or a device or a way of co-packaging or co-providing a product that can protect against 2 or 3 things: HIV and or pregnancy and or STIs. There are 6 potential MPTs towards the later stages of development. There's 5 products in phase 1 trials and 1 gel in a phase 3 trial. And these have really come on substantially in the last few years. The research underpinning this work was done in 2015. That was when microbicides was still a big deal. And we investigated people's preferences for these different products, and we've plugged that into a mathematical model, which I'm going to explain here. So we consider 5 products in this study: oral PrEP, an intravaginal ring, an injectable product, a microbicide gel, and this silks diaphragm, which could be used in concert with gel to provide multi-purpose protection. Our methods, we predicted uptake. So it's really difficult to get numbers for things which don't exist yet, and I'll come back to that shortly. We predicted uptake through discrete choice experiments. We used epidemiological evidence from South Africa to parameterize a simple static model, which is quite similar to the goals model in many respects. We simulated people through this model for 1 year of product use, assess our impact through averting HIV infections. We made a ingredients-based top-down cost model, and in the end, we estimate cost effectiveness. So the fun bit in this study is that these products don't exist. So how do we get a number of uptake for things which don't exist? In the diagram at the bottom here, we have our assumptions going into our big black box. Our big black box is our model, and out of our big black box, we get impact and cost effectiveness estimates. And one option is to look at assumptions from other studies, other demonstration projects for single-purpose products, or we have this nebulous expert opinion, which often informs lots of our models. And it really depends who your expert is, how reliable these numbers might be. So we asked people, we used a discrete choice experiment, which is a type of stated preference elicitation method to predict our uptake of single and multi-purpose prevention products. This was published last year in Medical Decision Making, and I'll leave you to look at that in your own time. I'm going to show you how we modeled impact. We parameterized our model using HSRC and some other epidemiological data from South Africa. And it's a simple linear association. It's not a fancy model. There's no dynamics going on here. It's a static model defining protection as a function of efficacy and use. So if you're into algebra, you can look at the bottom bit. If you're not, then stay with me. It's a simple model. We look at what people are doing now, how much condom use is going on. We've got condom users and non-condom users who are using the product and get additional protection from that. We have some people who stop using condoms as a result of using the new products, and we just add all of this together in our model. So we estimate our benefits from 1 year of product introduction. We model amongst 3 female groups: young and old. Old is obviously a subjective term. In this case, I mean over 25. In the general population in South Africa, and a female sex worker group as well. We modeled DALYs averted through preventing HIV infections and also reducing maternal mortality for the pregnancy prevention element of these products. We calculate DALYs without age weighting. We use a discount rate of 3% on everything. And there's tons of one-way and probabilistic sensitivity analyses, which I can go through with at great length if you so wish. We use a willingness to pay threshold. So if you're not familiar with economic evaluations, you can work out how much something costs and how much benefit you'll get, but you need to know if it's cost effective or not. So a common threshold is to use 3 times or 1 times GDP per capita. These are often too high. There's a study by Beth Woods at the University of York, which gives us some different numbers, some more conservative numbers for a cost effectiveness threshold in South Africa, which we use here. we make a cost model, we assume fixed costs and variable costs across these different things. I don't think there should be any surprises here. We assume that providers get trained, we assume there's some costs associated with products, and also we avert some health costs. So by preventing an infection, we're averting a lifetime's worth of ARV treatment, and we also prevent planned and unplanned miscarriages and births. We simulated 5 rollout scenarios. So remember, we've got all of these products, and we have to think of some way of introducing them. Scenario 1, current practice, as we've seen, single-purpose PrEP, protect against HIV, is currently in use. In the next few years, there's a potential for a single-purpose intravaginal ring. So we simulate that, and then further down the line, maybe, we can have a multi-purpose ring. So that's scenario 3, single-purpose PrEP plus a multi-purpose ring. We've got 2, what I've called kitchen sink scenarios. So we throw everything into this population and see what sorts of results we get. And I'll ask you to hold your skepticism until we get to the results. Scenario 4 is a single-purpose kitchen sink. So we're looking at single-purpose PrEP, microbicide, intravaginal ring, and injectable. The diaphragm will always protect against pregnancy, and we assume that that's used with the microbicide gel. Scenario 5 is everything as a multi-purpose product. So here are our results. We've got 3 clusters of bars, 1 for each population. We've got a horizontal dotted line, which is our willingness to pay threshold, and this is for averting 1 DALY. And you can see a clear pattern amongst younger women under 24, between age 15 and 24, and female sex workers. We see that pretty much everything is cost-effective at that threshold. Amongst the more old women group, we see that things are less cost-effective. They're above this threshold. The nuance here is that the 3rd light blue line and the 5th purple line are the multi-purpose prevention options. So all of the multi-purpose prevention options are more cost-effective than the single-purpose prevention options. And if you're into health economics and you're questioning our negative DALYs here, these are products that cost less and have more of an impact. So we've got this lovely model, but we need to see if it works or what its results are sensitive to. These are plots on the cost-effectiveness plane. Going diagonally on the plane is our willingness to pay. So if we're below this, to the bottom right of this line, our interventions are cost-effective. Now, I've plotted our point estimates, but I've also given a range around our incidence, so an upper and lower incidence for each group, and we see that our results are very sensitive to the incidence assumptions that we put in. So this means our model is sensitive to incidence, but it also means that the effectiveness and cost-effectiveness of these products could be very sensitive to incidence also. As we've seen, PrEP is already here. So what do we gain from adding these multi-purpose products? Well, we still see that adding a single-purpose vaginal ring to PrEP is cost-effective amongst younger and older women and female sex workers. Adding a multi-purpose ring to a scenario of just PrEP is cost-effective in all of our modelled groups. And if we had a range of all these single-purpose products, adding a multi-purpose product on top is largely cost-effective. So to conclude, our MPTs are likely to be cost-effective amongst younger women and female sex workers. And the most cost-effective scenarios that we modelled were with multi-purpose products compared to single-purpose products. And we think it's likely cost-effective to add a multi-purpose ring to single-purpose provision, be it PrEP. Our estimates were very sensitive to incidence. And sort of a broader takeaway of this study is the overall impact that we simulate is likely to be low. So we got as much impact as we could get out of this model as a bit of a hypothesis test. And we see a 19% incidence reduction amongst younger women, and then 8% incidence reduction amongst older women and sex workers. And if we hit these 90-90-90 targets, we'd see about a 48% reduction in incidence. So our call is that these things are potentially cost-effective, but they need to be part of a broader consideration. I'd like to acknowledge our funders, particularly USAID through PATH. our collaborators in South Africa, VITS RHI, and thank you guys for coming and listening through to Health Economics talks this afternoon.
Thank you very much. Do we have any quick question? Mic number 2.
Hello, Gus Cairns, AIDS Map. I meant to ask this of the Haitian presenter as well. I mean, I'm not cost effectiveness expert, but everything I've seen suggests the two biggest influences basically are background incidence and the absolute cost of the drug. And I don't think you put either of those up on your slides. So what assumptions did you use? And I was going to ask that of the Haitian study as well.
Good question. These are our incidence assumptions. So our central incidence for the younger group is 2.5, the older group 1.6, and sex workers is 5. I haven't got the cost data in my slides, but I'm more than happy to have a chat with you.
Using kind of costs typical of ART in South Africa?
Yeah, absolutely.
Okay.
And actually, these would be, our model are on the higher end of some more recent published costs where people have actually measured it as opposed to estimating it like we did.
Okay.
Thank you very much. Right, our last speaker is Jean-Michel Molina, who is a professor of infectious diseases at the University of Paris, Diderot. His primary clinical research interest lies in the area of treatment of HIV infection, and has been involved in a number of studies assessing new drugs. He's going to present to us a late breaker abstract looking at the incidence of HIV infection in the ANRS study in Paris, in the Paris region.
Thank you, Nyerazzo. Good afternoon, everyone, and thank you for staying for this last presentation. So on behalf of my co-authors and on the INRS Prevention Study Group, I would like to thank the program committee for selecting this abstract for presentation. These are my disclosures. As you may know, the INRS IPERGAY study have shown the high effectiveness of PrEP with oral TDF-FTC taken on demand in high-risk MSM, with an 86% relative reduction in HIV incidence versus placebo. And the efficacy was even higher during the open-label extension of the study, up to 97%. However, these data come from clinical studies, and we have yet limited data on real-world experience with on-demand PrEP. That's why we have implemented this ANRS Prevention study, with also the aim to confirm the public health impact of PrEP on the HIV epidemic, to try to replicate what has been seen in San Francisco and more recently in New South Wales. So this is the study design. This is not a randomized trial. This is an open-label prospective cohort study done in the Paris region, because that's the region the most affected by HIV in France. Participants enrolled in the study were HIV negative, high-risk adults who have an inconsistent use of condoms and a creatinine clearance above 50 ml per minute, and they have to be HBS antigen negative if they want to use an on-demand regimen. The study started enrollment May 3rd last year, and as you can see, participants actually made the choice to use PrEP either daily or on-demand, and they could actually switch regimen over time when they wished to. The study should end May 31st of 2020, with the main primary objective to show a 15% at least reduction in new HIV diagnosis among MSM in the Paris region. Follow-up was performed every 3 months with HIV tests, plasma creatinine level, STI screening, and recent guidelines in France recommend testing every 3 months for MSM. Condoms gel were also provided, as well as risk reduction and adherence counseling. In addition to the primary objective to show an at least 15% reduction of new HIV diagnosis among MSM in the Paris region, we have a number of secondary objectives listed in the slides, and we aim at enrolling at least 3,000 participants, probably 85% MSM, with the hypothesis that PrEP efficacy would be in the range of 80%. I'm going to present now an interim report of the data up to July 2nd of this year, with more than 1,600 participants enrolled across 22 sites. So these are the baseline characteristics of the participants. As you can see, the median age was 36 years. Most participants were Caucasian. Almost all were MSM, with only a few heterosexual men and women and transgenders. 57% had prior PrEP experience, and at the last sexual intercourse, up to 15.8% have used chemsex. If you look at the number of condomless sex acts in the prior 4 weeks, it was 2, and the median number of sexual partners in the prior 3 months was 10. Interestingly, 54.6% of the participants choose to use PrEP on demand. If we look now at the baseline characteristics according to the dosing regimen, you could see that the only difference between the two groups was actually the number of condomless sex acts and the number of sexual partners, which was higher with the daily PrEP use. All the time, you could see that the choice of dosing regimen remained quite stable, with 50% daily, 50% on demand, and at each visit, about 15% of participants actually switch regimen from daily to on-demand or vice versa. Let's look now at the adherence to PrEP and the use of condoms. These data summarize more than 2,000 sex acts in more than 1,000 participants who have reached at least the month 3 visit. What you can see is first that PrEP use was high, as expected in the daily arm. More than 98% of the participants said they have used PrEP at their last sexual intercourse. This proportion was a little bit lower with on-demand, 81%. What's interesting is that when people use PrEP, actually they use it correctly. Correctly meaning at least 1 pill before sex and 1 pill after sex. And you can see that up to 96% of the participants reported the correct use of PrEP. Also of interest, the use of condoms, self-reported condom use at the last sexual intercourse was in the range of 20%, and these are people who used condoms in addition to PrEP, for the vast majority. What about HIV incidence so far in the study? With more than 900 years of follow-up, you could see that the HIV incidence was actually 0 with daily and 0 with on-demand dosing, with an upper bound of the confidence interval of less than 1 per 100 years of follow-up. The mean follow-up in the study is so far short, only 7 months. But interestingly enough, the rate of study discontinuation is low, with only 3.3 per 100 years discontinuing the study, half of them because they were willing to discontinue PrEP. If we use the HIV incidence that we reported in the placebo arm of the NRS Hypergate study a couple of years ago among MSM in Paris, we could say that with the data we have today, we may have averted up to 85 HIV infection in the study. What about sexual behavior? You could see in dark blue participants who use daily PrEP, in light blue those who used on-demand PrEP. And you could see that all the time there was a slight increase in the median number of condomless sexual acts, and also an increase in the proportion of people who have condomless sex. There was, however, maybe a slight decline in the number of sexual partners over time. What about STIs? We don't have yet all data on bacterial STIs ready. They are still being analyzed by the review committee. But I can share with you the data on viral hepatitis. We have 11 cases of acute hepatitis reported so far, 5 with daily, 6 with on-demand. And you could see that most of them were acute hepatitis C infection, but we have seen also a couple of hepatitis A infection and even hepatitis E infection. There was no hepatitis B infection. In terms of adverse events, the incidence of drug-related adverse events was quite low and similar with daily and on-demand, 11 per 100 person years of follow-up. The main drug-related adverse events were gastrointestinal adverse events, as what has been reported before. In terms of grade 3 and 4 adverse event, it was mainly viral hepatitis, which I described just before, and also a number of neuropsychiatric adverse events, suicidal attempts in a number of participants. However, there was no treatment discontinuation in the study due to drug-related adverse events. In terms of lab abnormalities, almost all grades of ALT elevations were grade 1, with a similar incidence with daily and on-demand. Very few grade 3 and 4, which was participants who experienced actually acute hepatitis. In terms of creatinine elevations, only grade 1 elevations were reported, with a similar incidence again with daily and on-demand. So in summary, this interim report of an OBL label cohort study enrolling mostly MSM in the Paris region confirm the high efficacy of daily and on-demand PrEP in MSM. There was no breakthrough HIV infection so far, and up to 85 HIV infections have been averted. The participants who used daily TDF-FTC had more partners and more frequent sex than those using on-demand PrEP. Both had a high and correct use of PrEP. The safety profile of both dosing regimens was quite good, and there was no drug discontinuation because of adverse events. The retention rate was so far quite high. There was also a trend towards some increase in risk compensation that we need to monitor, and we hope to present at future meetings data on STI rates and the rate of HIV incidence. I think these data strengthen also the case for on-demand PrEP being an alternative to daily PrEP among MSM. As you may know, on-demand PrEP has been endorsed by French guidelines, UK guidelines, European guidelines, Canadian guidelines, even more recently, Australian guidelines. And today, the IAS USA guidelines for 2018 have been released and have also endorsed the on-demand regimen for MSM. And finally, I'd like to acknowledge all the participants in the study, the site investigators, the counselor, the trial scientific committee, the community advisory board, the NRS staff, INSERM, my co-PIs, Jad Ghosn, Daniela Rojas, and Dominique Costagliola, as well as the funders, INRS, but also SIDAction, the Île-de-France region, the City of Paris, AID. Thank you.
Very much, Jean-Michel. We'll have a question from mic number 4, then we'll come to mic number 2. Mic number 4?
Yes, thank you. It's Knut Schewe from Hamburg, Jean Molina. Thank you for this interesting talk and initiating very important follow-up studies on intermittent PrEP, where we certainly need more data. I have one question. Among those who only had on-demand PrEP, there was a 20% rate of patients who did not use the PrEP at the last sexual act. Was it because it was a low-risk act or because they used condom at that act?
It was only 20 sexual intercourses, so that was less than 2% of the people. So it means that overall in the daily PrEP arm, most individuals have used PrEP at the last sexual intercourse.
Okay, it was.
Thank you, Dr. Molina. The difficulty that we have is to define adherence, because what I understand is that you define adherence depending if he was on PrEP during the last act, because people are changing. What we see in our patients is people are taking for months, they stop, they start again, they change as their life change. And we have I think we should try to, like in Canada, we use more PrEP every day during summer than during winter. You can understand why. So the definition of adherence, the concept, I try to define that and I don't succeed.
Thank you. That's an important point, and I think adherence is even more challenging to assess with an on-demand regimen than with a daily regimen. But I think that the good thing about on-demand regimen is that it gives you a clear guidance on when to stop, how to stop, when to start, how to start.
6, number 6.
Thank you, Jean-Michel. Great study. Gustavo Loncel from Conrad. In the on-demand regimen, on average, how many fewer pills people took compared to the daily?
I cannot give you a clear estimate at this point from that study, but in prior study it was probably half of the pills.
Thanks.
Thank you. Mike, number 4.
Ariane van der Straten, RTI International. Thank you for a very exciting presentation. Can you clarify how adherence was measured? It seems like it was self-report. Did you have any ascertainment of use by drug level? And then what happened to the very few women who were enrolled? Were they all on daily, or did some of them choose the on-demand regimen?
Thank you. So regarding adherence, we are only presenting here preliminary results. We also have collected dry blood spots to look at drug levels in these people, so we will be able to report these data in the future. Regarding women, we only had 3 women and 9 heterosexual men, so it's going to be difficult to give you a more precise estimate on these 3 women, but they were on a daily regimen.
Thank you. Our last question from Mike, number 5.
Do you have any concern that there was a 19% rate of non-use of PrEP among the on-demand population?
That's a good question. I think we have to understand more why these people didn't use PrEP at their last sexual intercourse. Again, if I refer to previous work, it seems that these were sexual acts with their regular partners most of the time, so they knew the HIV status of their partner. We have to understand that in more details.
Allow me to thank our panel of presenters. We've had updates from the ACCESS study, the PrEP study, the EQUIP study, and we've also heard about the barriers and facilitators to PrEP, uptake and continuation of PrEP, and also the cost effectiveness of PrEP and MPTs. So I'd like to thank you all and wish you a good rest of your day. Thank you.